Your last blood pressure reading inflated your real number by as much as 7 points, and the fix takes under 5 minutes and costs nothing. A team led by Dr. Tammy Brady and Dr. Herong Liu at Johns Hopkins Bloomberg School of Public Health published in JAMA Internal Medicine in October 2024. They ran what they called the arms crossover trial, and they found that when the arm hangs unsupported at the patient's side during a blood pressure measurement, systolic pressure is overestimated by 6.5 points. Not because the cuff was broken, not because the patient's cardiovascular system changed, because of where the arm was resting when the button was pressed. The Johns Hopkins team noted that a 6.5-point overestimate is the difference between a reading of 133 and a reading of 140, and 140 is the threshold for stage 2 hypertension classification. The diagnosis or the near diagnosis or the prescription decision could hinge on that gap, and that gap was introduced before the measurement even began. Right now, you are in one of two situations. In the first, your readings have been accurate. Your arm was resting on a desk, cuff at heart level, back against the chair, feet flat. You'd been sitting quietly for at least 5 minutes before the cuff inflated. Your cardiologist has your real number. Every conversation you've had about where you stand has been grounded in something that reflects your actual resting pressure. That is door A. In the second situation, every reading on file, every number your doctor has seen, every reading you've taken at home was measured under conditions that added somewhere between 4 and 7 points to your real pressure. Your arm was resting on your knee, or hanging at your side, or you'd walked in from the parking lot 2 minutes earlier. The nurse wrapped the cuff while you were still settling into the chair, and the number that appeared has been shaping every conversation about your blood pressure ever since. That is door B, and the only way to find out which door is yours is to take one reading the right way and see whether it matches what's been recorded. By the end of this hour, you will know which door is yours. You will know exactly how a blood pressure reading can be inflated, not by disease, not by the food you ate, but by the position of one arm, and why that matters more than most people have been told. You will know the full measurement correction protocol, the steps that take under 10 minutes and bring a home reading as close to clinical accuracy as a consumer device can get. You will know 5 additional techniques, each with a specific documented effect size and a specific time horizon that can shift your number in the window between now and your next appointment. You will know what the research says about how much each technique realistically moves the systolic reading and how long that shift lasts, because those two facts are different for every technique and almost nobody explains both. And you will know one sentence, the exact words, that gets everything you learned today documented in your chart, so that whatever reading your cardiologist sees next time has a reference point attached to it. One thing before we go further, do not stop your medication based on this video. Do not skip a dose. Do not cut a pill in half. Do not change anything you are currently doing. What we are doing here is building understanding, so you can have a better conversation at your next appointment and bring more accurate data into the room. That is the whole goal. If you have your most recent blood pressure number written down somewhere, from a doctor's visit, a home cuff, a pharmacy machine, picture it now. Hold that number in your head. By the end of this hour, you will know whether it was measuring you or measuring the position of your arm. You sat in the chair in the waiting room. A medical assistant called your name, walked you back, and wrapped the cuff around your arm while you were still settling in. Maybe you'd come from the parking garage. Maybe you'd been moving quickly because you were a few minutes late. Your back wasn't fully against the chair. Your arm was resting on your knee. The cuff inflated. The number appeared. The assistant noted it and moved on, and later the cardiologist glanced at it and said something about where you stood relative to the target. And you left with that number in your head, the number that may have been reflecting your arm position as much as your arteries. Maybe you've been at home with a cuff, taking readings in the morning before coffee, doing what you were told, and the number keeps coming back higher than you expected. Or it swings. 128 one morning, 141 3 days later, and you can't figure out what changed because nothing obvious shifted. The variation might not be your blood pressure, it might be the chair, the arm position, the 2 minutes you waited instead of 5. Or maybe you've been told your numbers are well controlled and you're watching this because someone you care about is struggling with theirs, and you're looking for something concrete to pass on. That question, is the number I've been given actually mine, is what this hour is for. By the end of it, you will have the answer and you will have the words. There are 3 kinds of people watching this right now, and they are all in the right place. The first is someone recently told their blood pressure is elevated, or watching it creep toward a range that worries them, and trying to understand what the number actually means before a medication conversation happens. If that is you, the most important thing to grasp early is this: a reading and your blood pressure are not the same thing. A reading is what a device measured under specific conditions. Your blood pressure is what your cardiovascular system is doing over time. The gap between those two things is what this video is about. Pay close attention to what comes next and to segment 4, where you will get the exact sentence that opens the right conversation with your cardiologist without it feeling confrontational. The second is someone who has been managing their blood pressure for a year or more, medication, dietary changes, home monitoring, and is frustrated because the readings are still inconsistent or still not where they want them to be. If that is you, your frustration is not imaginary, and it is not the failure of your effort. There is a documented reason why home readings are often inconsistent, and it has nothing to do with whether you are doing something wrong. That reason becomes entirely clear in the segment that follows. The third is someone well-controlled, numbers where the doctor wants them, who is watching to understand the mechanism behind what's working, or to find something worth passing on to a family member who is not managing as well. If that is you, the bigger pattern near the end is built for you. It takes what you learned today and turns it into a framework for every number on a medical panel, not just blood pressure. No matter which of the 3 you are, what sits underneath all of this is the same. It starts with something that no blood pressure cuff in any doctor's office has ever measured you at. The reading you would produce if the arm were supported, the back were against the chair, and 5 minutes of quiet had passed before the cuff inflated. For most people, that reading has never been taken. Let's go find it. Here is what almost nobody tells you about the number your cardiologist has on file. Blood pressure is not a fixed property of your body. It changes by the minute, in response to movement, to conversation, to whether you stood up 3 minutes ago or have been seated for 20. What a cuff measures is a snapshot taken at one specific moment under one specific set of conditions. The conditions matter as much as the moment. Change the conditions and the number changes, not because your cardiovascular system changed, but because the measurement did. Think of a bathroom scale sitting on an unlevel floor. If the floor tilts 2 degrees, the scale reads heavier than you actually are. Not because you gained weight, but because the instrument is measuring something real under a condition that inflates the result. Correct the floor, and the number corrects with it. Blood pressure measurement works the same way. The reading is real. But if the setup is off, the reading reflects the setup as much as it reflects you. The ARMS trial, led by Dr. Tammy Brady at Johns Hopkins and published in JAMA Internal Medicine in October 2024, is the most rigorous recent test of how much arm position alone shifts the reading. The researchers tested 3 arm positions using automated cuff devices, the kind used in virtually all clinical offices and in every home monitoring kit currently sold. The guideline recommended position: arm supported on a desk, mid-cuff at heart level. The most common clinical alternative: arm resting on the lap. The most common home alternative: arm unsupported, hanging at the side because the person is sitting on a couch or bed with nothing to rest it on. Lap position overestimated systolic pressure by nearly 4 millimeters of mercury. Unsupported arm at the side overestimated systolic by 6.5 millimeters of mercury. The study was crossover. Each participant had their blood pressure measured in all 3 positions, so the comparison is within the same person. The overestimation was consistent, and it was not small. The Johns Hopkins team noted explicitly, a 6.5-point overestimate is the difference between a systolic of 133 and a systolic of 140. That classification, stage 2 hypertension, changes the conversation about medication. It can change whether a prescription is written, whether it's continued, whether a higher dose is recommended, and it can be introduced or removed entirely by where the arm rests during 60 seconds of measurement. This is not a flaw in the cuff. The cuff is measuring what it is positioned to measure. When the arm falls below heart level, the blood column has to work against gravity differently, and that hydrostatic difference registers as an elevation. The instrument is doing exactly what it is designed to do. The setup is introducing error that the instrument cannot correct on its own. Add what else the research identifies. Talking during a reading adds an average of 7 to 8 points to systolic per multiple studies. Crossed legs add 2 to 8 points. A cuff too small for the arm circumference, clinical cuff hypertension, adds 3 to 8 points. And the single reading approach, one reading treated as the measurement, ignores the natural minute-to-minute variability that is a feature of every functioning cardiovascular system. The American Heart Association's measurement guidelines have specified the correct protocol since at least 2017. Arms supported at heart level, back supported, feet flat, legs uncrossed, no talking, 5 minutes of quiet rest before the cuff inflates, and at least 2 readings on the same arm at least 1 minute apart. That protocol exists. It is not a secret. It is in the published guidelines. Here is why you have almost certainly never experienced it in a clinical setting, and it is not what most people assume. We will come to that in full in the segment after this one. Right now, here is what you can do immediately. Take 2 readings, same arm, 3 minutes apart. Between them, arms supported on a table or desk at chest height, back against the chair, feet flat, not talking, not looking at your phone. The 2 readings will almost certainly not match each other. The difference between them is information. It tells you how much your pressure naturally varies in a 3-minute window. The lower of the 2 is almost always closer to your actual resting pressure. Write both numbers down, write the date and time. That is the first piece of data that belongs entirely to you. This is the 2 reading gap. Same arm, same cuff, 3 minutes of quiet between measurements, and the readings diverge. Not because anything changed in your cardiovascular system, because a single reading is a sample, not a fact. Your cardiologist has been working, in most cases, from one sample taken under variable conditions. What this hour is about is what you do once you understand that. Do not stop your medication based on any reading you take at home. Do not change your dose. What you are doing right now is collecting better data and bringing that data to your cardiologist. The conversation that follows is what the next segment builds toward. The question sitting in your head right now is probably this: if the measurement is this sensitive to a single variable, arm position, what else moves the number and how much? The answer is where it gets specific. And understanding the mechanism makes everything else in this video land differently. Your blood pressure at any given moment is the product of 3 things working together: how hard the heart is contracting, how much blood is in circulation, and how much resistance the walls of your arteries are offering to flow. That third factor, arterial resistance, is the one most directly modifiable in a short window, and it underlies every technique in this video that shifts the reading within minutes rather than weeks. Think of it this way: blood moving through your arteries behaves the way water moves through a hose. The pressure at the end depends on the pump, the volume of water, and how wide or narrow the hose is. Narrow the hose, pressure climbs; widen it, pressure falls. Your arteries are not rigid pipes. They are muscular, dynamic tubes that narrow and widen in response to signals from your nervous system and from your blood chemistry. The interventions that shift blood pressure quickly all work by sending one of those widening signals. Here is what changes for that mechanism after the age of 65. Arterial walls accumulate structural changes over decades. The elastic fibers that allow younger arteries to expand and recoil with each heartbeat gradually stiffen as calcification and collagen cross-linking build up over time. This stiffening is why blood pressure tends to rise with age, even in people who are otherwise healthy. And it is why arteries at 65 respond more slowly to vasodilatory signals than they did at 35. A technique that drops systolic pressure by 8 points in a 40-year-old may produce a 4-point drop at 65. The biology is the same. The magnitude differs because the arterial walls have less range of motion to work with. This is not a reason to skip the techniques. It is a reason to understand what a realistic result looks like in your body at your age, rather than comparing your numbers to a study that enrolled people 30 years younger. The first intervention, the measurement correction protocol itself. Not a breathing exercise, not a supplement, the setup. The full protocol the AHA guidelines specify has 5 components. 1. Arms supported at heart level, mid-cuff on a desk or table at the height of your chest. This alone, per the ARMS trial, eliminates the 4 to 7 point positional overestimate. 2. Back fully supported against the chair. Leaning forward engages postural muscles that elevate the reading. 3. Feet flat on the floor, legs uncrossed. Crossed legs add 2 to 8 points by compressing the veins of the lower leg and increasing venous return to the heart. 4. 5 minutes of quiet, seated rest before the cuff inflates. Not 2 minutes, not the time it takes to sit down. 5 minutes of genuine quiet, no conversation, no phone screen. This single component is the one that appointment time constraints make nearly impossible in a standard clinical visit, which is why home measurement, done correctly, can actually produce a more accurate reading than the one your cardiologist recorded. 5. 2 readings, same arm, 3 minutes apart, average of the 2 recorded and brought to the appointment. That protocol takes approximately 10 minutes total. The readings take under 5. The waiting is the work. And what it produces is a number that reflects your resting cardiovascular pressure. Not your arm position, not your walk from the parking lot, not the 60-second constraint of a clinical measuring moment. The second intervention. Slow breathing at 6 breaths per minute. Inhale for 5 seconds. Exhale for 5 seconds. That is 1 breath. Repeat for 5 minutes. This is the technique the title of this video refers to, and the evidence behind it is specific enough to use without exaggeration. Multiple meta-analyses covering 22 randomized controlled trials and more than 1,300 participants with above normal blood pressure or diagnosed cardiovascular disease found that slow, deep breathing produces an average systolic reduction of approximately 6 millimeters of mercury and diastolic reductions of 3 to 6 millimeters of mercury. A 2024 study published in Frontiers in Physiology examined slow breathing specifically at 6 breaths per minute and found that for participants with systolic pressure at or above 130, 15 minutes of this pattern produced a 9.7-point reduction in systolic immediately following the session. For 5 minutes, studies consistently show acute reductions in the 3 to 6 point range. The full 9.7-point shift requires closer to 15 minutes of practice. The mechanism is the vagus nerve. This is a long nerve that runs from the base of your skull through your chest and into your abdomen, regulating heart rate, vessel tone, and the parasympathetic nervous system. When you slow your breathing to 6 breaths per minute, the pressure that builds inside your chest during a full inhale stimulates the vagus nerve directly. The vagus nerve signals the heart to slow and signals the arterial walls to widen, applying the same vasodilatory mechanism described above, but using a breath instead of a drug. Wider arterial walls, lower resistance, lower pressure. The effect is measurable in minutes. 2 things to understand about this effect. First, it is acute. The reduction lasts for hours, not days, from a single session. This is not a permanent fix from one morning's practice. Second, consistent daily practice builds a cumulative, sustained benefit over weeks. Research across multiple studies shows that breathing exercises used daily for 4 to 12 weeks produce resting blood pressure reductions of 4 to 5 points that persist beyond the session itself. The session-by-session effect and the long-term training effect are different, and both are real. Practically, do not take your home baseline reading immediately after a breathing session, because the reading will reflect the post-breathing state, not your resting state. Take the baseline reading first. Do the breathing session separately. If you bring both numbers to your cardiologist, resting baseline and post-breathing, you have given them 2 pieces of information instead of 1. The third intervention, isometric hand grip. Squeeze a firm object, a rubber ball, a folded towel, and inexpensive grip trainer at approximately 30% of your maximum grip strength. Hold for 2 minutes. Rest for 1 to 3 minutes. Repeat 2 to 3 more times. The total session takes under 12 minutes. A 2023 trial published in the Journal of Clinical Hypertension, led by researchers at the University of Portsmouth, found that isometric hand grip training 3 times per week for 12 weeks produced a mean systolic reduction of 11.2 points in unmedicated hypertensive adults. That is a larger average effect size than most single pharmacological interventions in comparable populations. And research published in 2023 confirmed that a meaningful portion of that benefit is retained when sessions drop to once per week after the initial training period. The mechanism involves arterial wall remodeling and improvements in endothelial function, the tissue lining the inner walls of your arteries that governs how readily those walls expand in response to increased flow. Repeated brief periods of elevated internal pressure during isometric contraction appear to train the arterial walls toward better baseline tone and responsiveness over time. In adults over 65, endothelial function is partially compromised by age-related stiffening, so the magnitude of the response tends to be somewhat smaller than in younger study populations. But the direction is the same. Consistent isometric work moves the number down, and the evidence in older populations confirms the effect is real. The acute reduction from a single hand grip session, what happens in the hour or two after you put down the grip trainer, is modest, typically 3 to 5 points systolic. The long-term reduction from 12 weeks of consistent practice is 11 points. If your reading tomorrow is similar to today's after starting this week, that is not evidence the technique is failing. This technique works through accumulation, not through a single session's response. Now here's where it gets important. The question that is probably forming right now is the one that everyone asks at this point in the explanation. If this measurement research exists, if these techniques have this level of evidence, why has my own cardiologist never mentioned any of this to me? The answer is not negligence. It is not a conspiracy. It is something more specific than either. And once you understand it, the conversation you have at your next appointment will be completely different. Here is what that appointment actually felt like. The chair in the waiting room had magazines from 3 months ago on the side table. You filled out a form or checked in on a tablet, and then you waited. Your name was called, and you followed someone back through a door. The hallway was busy. Someone else was coming out of another exam room. A phone was ringing at the nurse's station. You went into a small room and sat down. Within 90 seconds of sitting down, before you'd fully settled, the cuff was on your arm. Your arm was in your lap because there was nothing on that side of the chair to put it on. You hadn't been told to do anything differently. Nobody mentioned the arm position. The cuff inflated, beeped, displayed a number, and deflated. The number was noted. You were told the doctor would be right in. Later, when the cardiologist entered, the reading was already on the screen. It was the only reading for that visit. There was no comparison, no second reading 3 minutes later, no note about arm position. It was just the number. And the conversation proceeded from that number as if it were a verified biological fact rather than a single sample taken under unstated conditions while you were still settling into a chair. That is not a criticism of your cardiologist. It is a description of what the appointment structure makes possible. The cardiologist came in, looked at the chart, interpreted what was there, and made clinical decisions based on the best available data in the time allotted. What was missing was not care. It was a measurement protocol that requires time the appointment does not contain. That gap between what the protocol requires and what the appointment allows is what this hour is designed to help you close. The way you close it is not by showing up angry, it is by showing up with better data. Now, blood pressure follows a pattern through the day that almost no single clinic visit captures. In most people, pressure is at its lowest in the hours just before waking, roughly 2 to 4 in the morning. Beginning about an hour before the alarm goes off, it starts rising. By 6 to 8 in the morning, it has climbed significantly, a surge driven by the activation of the sympathetic nervous system as the body shifts from sleep to wakefulness. This morning's surge is real, it is measurable, and it is physiologically meaningful as an independent cardiovascular risk signal. It is also the hour at which almost no cardiologist appointment is scheduled. A reading taken at 10 in the morning in a clinical setting is measuring you during a different phase of that circadian curve than a reading taken at 7 in the morning before medication. Neither is wrong. They are not comparable without knowing when each one was taken. The recommendation from measurement guidelines is to take home readings at the same time every day, early morning, before medication, before food, because that window produces the most reproducible reading across days and the most meaningful comparison across weeks. It is also the window most likely to capture elevated pressure that doesn't show up at a midday clinic visit. Write the time on every reading you take. It is data. Without it, the number is only half the picture. Here is what that stiffening process looks like from the inside, because understanding it changes what you expect from each technique. The inner lining of your arteries, the layer called the endothelium, produces a molecule called nitric oxide. Nitric oxide is a signal that travels from the endothelial cells to the smooth muscle cells just beneath them, telling those smooth muscle cells to relax. When the smooth muscle relaxes, the arterial wall widens. When the arterial wall widens, blood flows more easily and pressure drops. This is the vasodilatory mechanism, the same pathway that breathing techniques, isometric exercise, and certain dietary compounds all use to lower blood pressure. They all, in different ways, increase the signal or the sensitivity of the response. After the age of 60, nitric oxide production from the endothelium declines. The smooth muscle cells become less responsive to the signal even when it is present. And the collagen cross-linking and calcium deposits that accumulate in the arterial wall over decades reduce the physical capacity of the vessel to widen, regardless of what the smooth muscle is doing. The arteries are less elastic. The signal is quieter. The response is slower and smaller. This does not mean the techniques don't work. It means the magnitude of the effect at 65 is smaller than the magnitude at 45, and the time to observe the effect for techniques that work through accumulation rather than acute response is longer. Isometric hand grip training in a study that enrolled 40-year-olds may show systolic reductions of 10 to 12 points in 8 weeks. In adults over 65, the same protocol may show 5 to 7 points over a longer period. Both are clinically meaningful. The comparison to the younger population's number is the wrong benchmark. The question is whether the technique moves your specific number in a consistent direction over time, and the research in older populations confirms that it does. The measurement correction protocol, by contrast, has the same effect regardless of age. A cuff positioned on an unsupported arm overestimates systolic pressure by 6.5 points, whether you are 40 or 75. The correction is a setup change, not a biological response, and setup changes are age neutral. This is why the measurement correction is the first intervention. It does not depend on arterial elasticity, endothelial function, or any biological variable that declines with age. It depends entirely on where the arm is resting when the button is pressed. Your cardiologist sees, on average, somewhere between 1,500 and 2,500 patients per year. A standard outpatient cardiology appointment runs 15 to 20 minutes. In that window, the cardiologist reviews the chart, checks current medications, addresses the presenting concern, interprets any new test results, and decides on next steps. Blood pressure is recorded, typically by a nurse or medical assistant, often before the physician enters the room, as one of several vital signs noted in the margin of a 15-minute slot that is already fully allocated. There is no dedicated 5-minute quiet sit. There is no deliberate arm positioning protocol. The measurement happens in the 60 seconds that are available, not the 10 minutes that the guidelines require. This is not negligence. This is the structure. A cardiologist operating within the standard appointment framework is not failing to follow guidelines by moving quickly. They are doing what the system has built time for. The American Heart Association published its updated blood pressure measurement guidelines in 2017, specifying arms supported at heart level, back supported, feet flat, 5 minutes of quiet rest before the cuff inflates, and at minimum 2 readings averaged together. Those guidelines have been available for nearly a decade. The ARMS trial confirming that common arm positions overestimate systolic pressure by 4 to 7 points was published in JAMA Internal Medicine in October 2024, 7 years after the guideline, and in a journal that clinical cardiologists monitoring a patient panel of 2,000 people are not systematically reading cover to cover each month. The research moves faster than the clinical workflow. The clinical workflow moves faster than the guideline revision. The guideline revision moves faster than the institutional change to appointment structure. Every step in that chain has a lag built into it, and the lag is not the failure. The lag is how medicine moves. The same gap applies to the interventions. The isometric hand grip evidence base has been accumulating for more than a decade, but the most rigorous recent data, the 2023 University of Portsmouth trial showing 11-point systolic reductions over 12 weeks, the 2024 Sports Medicine Review identifying isometric exercise as producing larger average effect sizes than aerobic exercise for blood pressure reduction, sits in literature that a busy cardiologist monitors incompletely because the literature volume across all of cardiovascular medicine is impossible for any individual clinician to track in full. The 2017 AHA/ACC hypertension management guidelines do not include isometric exercise as a recommended intervention with a specific protocol. A cardiologist following the current guideline is not wrong. They are working from the best codified recommendation available. The best codified recommendation is not the same as the best available evidence. This is what the structural villain looks like, not a person, not an institution. A timing problem in a large, slow-moving system, where the pipeline from research finding to clinical guideline to updated workflow typically runs 5 to 15 years. Your cardiologist is not keeping this from you. Your cardiologist is running a 15-minute appointment with the tools the system has given them. The tool that is missing from that appointment is the 5 minutes of quiet time, the desk at chest height, and the second reading 3 minutes later. You can bring those tools in with you. That is the whole point. The research exists. The guidelines acknowledge it. The appointment cannot implement it on its own. The someone who bridges the gap, who walks in with a measurement log taken under protocol conditions, a specific citation, and a documentation request, is you. Not as an adversary, as a contributor, the person your cardiologist will actually want to see. Now here is the conversation. Exactly what you say, what you ask for, and what you do with the 3 possible responses. Before the appointment, write down 4 things. Your home readings for the past 2 to 4 weeks, date, time, arm used, protocol conditions. A 1-line note on whether you've been using the full protocol or want to start. The name of one specific intervention you want to ask about with the study reference. And the keystone sentence you're going to use at the end of the conversation. At the appointment, lead with the data. I've been taking home readings for the past few weeks and I want to share them with you. I started following the full AHA measurement protocol, arm on the desk at chest height, 5 minutes of quiet before each reading, 2 readings averaged. And I wasn't sure how those compared to what's in the chart. That is the opening. It is not an accusation that previous readings were wrong. It is a contribution of data, offered as a collaborative comparison. The second sentence, if the conversation continues. I read a study from Johns Hopkins published in JAMA Internal Medicine last October, the ARMS trial. They found that arm position alone can overestimate systolic pressure by up to 6.5 points. I wanted to ask whether that changes anything in how readings are being taken here, or whether it's something worth checking at home. 3 responses are possible. The first, the cardiologist knows the research and is already thinking about it. This happens, and when it does, you are ahead of where most patients start. The second, the cardiologist is not familiar with this specific paper but is open to it. What was the citation? This is the most common response to a patient who brings a specific, verifiable study from a legitimate institution published in a credible journal. The third, the cardiologist is pressed for time or dismissive. This also happens. It does not mean the conversation failed. It means the appointment was at capacity, and the record still exists. In all 3 cases, the next sentence is the one that matters most. The one that turns the conversation into a chart note regardless of how the appointment went. Would you be comfortable noting in my chart that at today's appointment, I asked about measurement protocol, specifically the arms trial on arm positioning, and whether we could have at least one reference reading taken under guideline conditions at a future visit, so there's a comparison point on record? That sentence asks for nothing that violates existing clinical guidelines. It requests a documented reference reading under conditions the guidelines already specify. It does not accuse. It does not demand a medication change. It does not challenge the cardiologist's clinical judgment. It asks for one note, one reading, and one comparison point. That is all. If the cardiologist agrees, that reference reading travels with you on your chart to every future appointment, every specialist consult, every new clinician who opens your file. If the cardiologist declines, asks for that to be noted, would you be comfortable noting that I asked about this today? A note that the question was raised is still a record. It is still data. Do not argue. Do not show frustration. You are not there to win a debate. You are there to add one specific piece of information to your chart and to ask for one reading to be taken correctly. Both are achievable in 2 minutes of a respectful appointment conversation. If the isometric hand grip conversation comes up, the sentence follows the same structure. I read about a protocol for isometric hand grip exercise, squeezing a grip trainer at 30% of maximum force for 2 minutes, repeated 3 times a week. A 2023 Journal of Clinical Hypertension trial found an average systolic reduction of about 11 points over 12 weeks in hypertensive adults. Would you be comfortable noting in my chart that I asked about this today and whether it's appropriate given my current treatment plan? That is a documentation request. Whatever response you receive, yes, modify it, not recommended, is now on your chart. You leave with a record of the question and the clinical judgment that followed it. That record is more valuable than the answer itself because it makes the next conversation easier and makes the longitudinal picture more complete. Sodium in the same framing. If dietary sodium comes up with your cardiologist, the most useful thing you can say is a specific number. My estimated sodium intake over the past week averaged approximately 1,800 milligrams per day is clinical information. I've been cutting back on salt is not. Track sodium in milligrams per day for 1 week before your appointment. Read the label on 5 items you eat regularly, do rough daily math, bring the average. Vigorous exercise causes approximately 1,400 milligrams of sodium loss per hour through sweat, which means a morning workout before a home reading shifts your sodium state and can artificially lower the measurement. Note the timing of exercise alongside your readings. Your cardiologist now has context they didn't have before. Sleep, finally. Raise it if it hasn't been raised. 7 hours of consistent sleep, same bedtime, same wake time, is associated with the lowest cardiovascular mortality rates in population-level data. Poor sleep elevates overnight blood pressure, impairs the normal overnight dipping that gives the cardiovascular system its recovery window, and raises morning cortisol that primes the sympathetic nervous system for elevation. A person sleeping 5 hours a night and seeing elevated morning readings may be measuring the cost of sleep deprivation as much as their underlying resting pressure. That is worth saying plainly to your cardiologist. It is a variable that is contributing to the number. It is adjustable. Now picture yourself at the next appointment. You walk in with a note in your phone. 4 weeks of home readings taken under the full protocol, time-stamped. You have a study name and a citation. You have the sentence. You sit down, and when blood pressure comes up, you say, "Here is what I've been collecting. Here is what I'd like to ask about. And here is one thing I'd like noted." The cardiologist looks up from the screen. In 15 appointments today, you are the one who arrived with a measurement log, a citation, and a specific documentation request. You are not asking for more time. You are not asking for a medication change. You are asking for one note on a chart, the kind of note that, if it contains a reading taken under guideline conditions, turns a single data point into the anchor of a longitudinal record. Picture the second moment, a dinner with your adult child, or a call with a sibling, or a conversation with a friend who just told you their cardiologist said their blood pressure was elevated and they're not sure what to do next. You have something specific to say to them, not drink less coffee and take a walk. You have a study name, a protocol, and a sentence they can use at their next appointment. You have lived the hour they haven't had yet, and you know what it produces. That is the share, in not a video link passed along without context, but a specific thing you understood that they need to understand too. The person who walks into a cardiologist's appointment with a measurement log, a study citation, and a chart note request is not a difficult patient. They are the patient who makes the appointment more productive than it would otherwise be. The person who passes that framework on to someone else is the reason their family member's next appointment goes differently. That is the identity. Not a patient managing a number, a person who understands the instrument well enough to use it correctly, to ask that it be used correctly on their behalf, and to teach someone they love to do the same. That skill does not expire. It does not require a follow-up purchase. It belongs to you now, and it works at every appointment, for every result, on every panel your cardiologist hands you on a printout for the rest of your life. Here are the 5 questions people ask most often about this, and the answers that make them useful rather than vague. The first, how do I know if my home cuff is actually accurate? Most home blood pressure monitors sold by reputable manufacturers are validated for accuracy within 2 to 3 millimeters of mercury under correct conditions. The limiting factor is almost always cuff size, not device accuracy. If the cuff bladder does not cover 80% of your upper arm circumference, the reading is inflated regardless of the device's listed accuracy. This is clinical cuff hypertension, and it adds 3 to 8 points to the systolic reading consistently. Have your home cuff compared against a clinical reading at your next appointment. Take both readings within 5 minutes of each other, under the same protocol conditions, on the same arm, and note the difference. A consistent gap of 5 points or more is worth discussing with your cardiologist as a calibration question, not a medical emergency. The second, should I be worried if my blood pressure is higher in the morning than in the evening? No and yes, depending on what higher means. Blood pressure follows a circadian curve. Lowest in the early pre-waking hours, rising through the morning, peaking in the mid-morning or early afternoon, declining through the afternoon, and dipping through the night. A 10 to 15 point difference between an early morning and an early evening reading in the same person is normal physiological variation. What the research identifies as clinically meaningful is not the size of the morning to evening difference, but the absolute level of the morning surge, particularly in people with diagnosed hypertension, where a pronounced morning surge represents an independent cardiovascular risk signal that afternoon clinic readings structurally cannot capture. This is why consistent timing matters. Same time each day, before medication, before food, because the pattern across days at the same time point is more informative than any single comparison across times of day. The third, my home readings vary a lot. Is that a sign something is wrong? Beat to beat and minute to minute variability is a feature of a normally functioning cardiovascular system, not a sign of dysfunction. 2 readings, 3 minutes apart in the same person under the same conditions will almost always differ by 3 to 8 points, sometimes more. A reading of 150 after you've been walking is not the same clinical event as a resting reading of 150 taken after 5 minutes of quiet. What you are looking for in home monitoring is the trend across multiple resting readings taken under the same conditions, not the outlier that doesn't fit the pattern. A consistent upward trend in resting readings over 2 to 4 weeks is worth bringing to your cardiologist with the log attached. A single elevated reading on a day when you were stressed, tired, or walking in from a cold day is information, not an emergency. The fourth, can I use the breathing technique right before my appointment to bring the number down? You can, and it will produce a lower reading. Slow breathing at 6 breaths per minute for 5 minutes before a clinical reading will reduce systolic pressure by 3 to 6 points acutely, based on consistent findings across multiple meta-analyses. If you do this, tell your cardiologist exactly what you did and when. A reading taken 10 minutes after a 5-minute breathing session is not the same as your resting baseline, and your cardiologist needs to know that in order to interpret the number correctly. The most valuable reading you bring to an appointment is the resting baseline taken under the full protocol. Arm on desk, 5 minutes of quiet, no preceding intervention. Bring that number. If you also have a post-breathing reading to compare it to, bring that too and label it. Do not stop your medication before an appointment to test what your number looks like without it. Do not stop your medication based on this video. The fifth, what is your angle here? And why are you telling me all of this? There is no supplement at the end of this video. There is no program, no membership, no product. The angle, if there is one, is this: a person who understands what their blood pressure reading is actually measuring and what it isn't, has better conversations with their cardiologist, produces more accurate data for clinical decisions, and is less likely to be over or underdiagnosed on the basis of a single measurement taken under unstated conditions. This channel produces long-form explanations of cardiovascular research for people who are managing a number on a panel and want to understand it at a level deeper than it's elevated. Here's the target. That is the product. The appointment conversation you will have differently after watching this hour is the whole point. Here is the wider truth. Every number on a medical chart is a measurement taken at a specific moment under specific conditions. Your LDL was drawn after a fast of a specific length, from blood processed in a specific way, interpreted against reference ranges derived from specific populations. Your fasting glucose was drawn at a specific time, reflects a specific recent dietary history, and varies meaningfully based on what was eaten the night before. Your bone density scan reflects the position of the scanner and the software version that processed the signal. None of these numbers are wrong. They are real measurements of real biology. But they are measurements, not verdicts. And measurements have conditions attached to them that are almost never stated on the printout. The skill you practice today is asking what the measurement conditions were, understanding how those conditions affect the reading, and knowing how to ask for a reference reading under controlled conditions is not a blood pressure skill. It is a medical literacy skill. It applies to every result your cardiologist has ever handed you on a printout and to every result they will hand you going forward. The number has always been more specific than it appeared. The conditions were always there, attached to the reading, unstated. Now you know to ask for them. Some readings will be fine. Some will show that something genuinely needs attention even when the protocol is perfect. Measurement correction does not guarantee a lower number. It guarantees a more accurate one. And a more accurate number, whatever it turns out to be, is better data for every decision that follows. You didn't get here by accepting the first number. You got here by asking what it actually means. That is the only thing this video asked you to keep doing. Take the readings, use the protocol, write down the numbers with the date, the time, and the conditions. Bring them to your next appointment with the one sentence, the exact words for the chart note request, already written in your notes. And share this with the one person in your life who has been sitting with a number they don't fully understand yet. They deserve the same hour you just gave yourself. If your next question is about what the LDL number on your cholesterol panel is actually measuring and what conditions affect that measurement the way arm position affects blood pressure, that video is linked below. The measurement question we covered today applies there too, in a different form. The next hour starts where this one ends. Let's go deeper on the two futures, because the identity shift is not a motivation speech. It is a prediction of what a specific kind of knowledge actually does when you carry it forward. The first future. Your next cardiology appointment is in 6 weeks. You have been taking home readings every morning. Same time, same arm, same chair, arm on the desk, 5 minutes of quiet first, 2 readings averaged and logged with the date and time. You have a 4-week log. You have done the slow breathing protocol 4 times a week, separately from the baseline readings, and you have a separate log for what the post-breathing readings show versus the resting baseline. You have been doing isometric hand grip 3 times a week, not every day, not when you're unwell, but 3 sessions a week consistently with a note of how the readings trend over the week following each session. You walk into the appointment. The medical assistant takes your blood pressure in the hall, arm on your knee, 60 seconds after you sat down, 1 reading. You know what that number reflects. You don't panic and you don't dismiss it. You write it down in your notes, labeled clinical reading, arm unsupported, no pre-reading rest. When the cardiologist comes in and the blood pressure topic opens, you take out your phone. I've been doing home monitoring for 4 weeks with the full protocol. Arm on the desk, 5-minute rest, 2 readings averaged. Here are the numbers. You show the log. The numbers are specific, time-stamped, and comparable across days. They may be lower than what was just taken in the hall. They may be similar. Either way, they are more information than the cardiologist had 30 seconds ago. You ask about the arms trial. You ask about the isometric hand grip protocol. You use the keystone sentence. The conversation takes 3 minutes. What it produces is a chart note that specifies measurement conditions, a documented reference reading, and a note that you asked about an evidence-based, non-pharmacological intervention and the clinical assessment of its appropriateness for your situation. You leave with a chart that is more useful than the one you arrived with, not because you argued, because you contributed. The second future. It is 3 months from now, a family dinner or a phone call on a Sunday afternoon. Someone you love, your adult child, a sibling, a close friend, mentions that their doctor told them their blood pressure was high and they need to think about whether to start medication. They are confused and a little scared. They don't fully understand what the number means. They don't know if the reading was accurate. They don't know what they can do between now and the next appointment. You know exactly what to tell them. You tell them about the 2-reading gap. Same arm, same cuff, 3 minutes apart, and the readings diverge because a single reading is a sample, not a fact. You tell them about arm position, desk, not lap, not side, cuff at chest height, and what Johns Hopkins found when they tested it. You tell them about 5 minutes of quiet before the reading and why home monitoring done correctly can produce more accurate data than the clinical measurement taken in the hallway. You tell them about slow breathing for 5 minutes and what the acute reduction looks like, and that the long-term benefit from daily practice is a different, larger number than the session-by-session effect. You tell them about the sentence, the exact words that get the measurement conditions documented on the chart, and the chart note that turns one reading into the anchor of a longitudinal record. You pass on 1 hour of understanding in 10 minutes, not because you are a cardiologist, because you spent 1 hour asking the right questions. And now you know what the instrument is measuring and what it isn't. That is transferable. That is what the second future looks like. The identity is not complicated. The person who knows that a blood pressure number is a measurement taken under conditions, not a verdict handed down by biology, walks into every clinical encounter differently, not with confrontation, with data, with a specific citation, with a keystone sentence already written in the notes, and with the capacity to pass all of that on, intact and useful, to someone who is sitting exactly where you were sitting before this hour began. That person has always been available to you. The only thing separating you from them was one specific piece of knowledge about what the instrument is actually measuring. Now you have it. Let's be specific about the timeline, because vague claims about research taking time to reach patients are easy to dismiss. Concrete numbers make the lag visible. The 2017 American College of Cardiology and American Heart Association hypertension guidelines redefined the threshold for hypertension from 140 over 90 millimeters of mercury to 130 over 80. This was the largest redefinition of the hypertension threshold in more than a decade, and it immediately reclassified approximately 14% of the U.S. adult population, roughly 31 million additional people, as having stage 1 hypertension. The measurement protocol those guidelines specify, 5 minutes of quiet rest, arm at heart level, 2 readings averaged, was included in the same document. Both the threshold change and the measurement protocol were published simultaneously in November 2017. The arms trial testing, whether arm position systematically introduces measurement error, was published 7 years later in October 2024. It was not that the question was unknown in 2017. Earlier studies had suggested the effect. It was that the 2024 ARMS trial provided the cleanest, most directly applicable evidence from automated cuff devices under typical clinical conditions. The guideline could not cite a study that had not yet been conducted. Between November 2017 and October 2024, an unknown number of patients were classified as hypertensive, near hypertensive, or well-controlled based on readings taken with the arm in a non-standard position. The 2024 ARMS findings do not invalidate those readings. They contextualize them. They say your reading was real, and it may also have been inflated by a specific, correctable, protocol-related factor. Those two things are not in conflict. A reading can be simultaneously real and influenced by conditions that add to the signal. The gap between the publication of the ARMS trial in October 2024 and the incorporation of its specific findings into the next round of clinical guidelines, whenever that happens, will likely be 3 to 7 years. That is the typical pipeline from a high-quality randomized trial published in a top journal to formal codification in a major professional society guideline. During those 3 to 7 years, the finding is available. It is verifiable. It is in JAMA Internal Medicine, one of the most read clinical journals in the world. And it is not yet in the guideline your cardiologist uses as the standard reference for clinical decision-making. That is the gap. It is not anyone's fault. It is the pace at which a distributed system composed of researchers, journal editors, guideline committees, professional societies, and clinical workflows moves from a finding to a recommendation. The gap is structural. The patient who bridges it, not by demanding the cardiologist change everything immediately, but by bringing the citation, asking the question, and requesting the documentation, is doing what the system cannot yet do automatically.